So my first bit of my PowerPoint got cut off, so I figured I'd just make another video, basically showing what was missed, because it was just my first two slides. So my opening slide basically went with this, like this. Hi, my name is Gabrielle McClure. I did my senior thesis on neurofeedback as an alternative treatment for post-traumatic stress disorder. I also covered neurofeedback as a diagnostic tool for PTSD because I believe that even though, well, while PTSD has a large biological effect on people, that biological basis should be used in its diagnostic capabilities because the diagnosis is just as important in deciding the treatment as the treatment itself is in the end. On the first page, I also had a image of two MRI scans of two different people, one person with PTSD diagnosis and one without. And I described how the PTSD brain had heightened activity compared to the non-PTSD brain, and how that showed that life events in PTSD, that trauma can affect the brain biologically over time. So then on the next slide, it was just post-traumatic stress disorder as an overall kind of description. And I said that I know most of the people who are seeing this are either psych professors or psych students, so I didn't want to go too deep into it. I basically had the DSM-5 lists five main criteria for a PTSD diagnosis: to have been exposed to actual or threatened violence, serious injury, or death, sexual violence, serious injury, or death; 2, to have at least one intrusive symptom associated with the traumatic event; 3, to actively avoid the stimuli associated with the traumatic event; 4, to have negative alterations in cognitions and mood associated with the traumatic event; and 5, to have marked alterations in arousal and reactivity associated with the traumatic event. Further symptoms that aren't actually listed in the DSM-5, but that are commonly cited by people with a PTSD diagnosis, are also having trouble falling or staying asleep, difficulty concentrating, hypervigilance, exaggerated startle response, and outbursts of anger. In the US, PTSD is currently diagnosed in 3.5% of the population, with an 8.7% chance of people getting PTSD throughout the lifetime. The most at-risk groups are veterans, survivors of rape, and people with trauma-involved careers. And the two mainstream treatments for PTSD are trauma-informed psychotherapy, or CBT, and pharmaceuticals. A meta-analysis done in 2016 on current PTSD treatments described that less than 50% of patients with the diagnosis that do go to get help and treatment have their symptoms notably reduced. Currently, the other 50% can sustain their diagnoses anywhere between 12 months to 50 years, which is a chronic PTSD diagnosis definitely at that point. Another issue with current treatments available is that people often drop out of treatment due to an increased resistance to treatment over time and decreased treatment retention, as well as a fear of re-traumatization when going over those emotional related memories in treatment. And then we go on to the neurofeedback slide, and that should be in my video.